thanks for the invitation to present a trial that Philips is supporting. I think it's well, in my point of view, one of the most important trials that are gonna change things in the future years. And it's the management in terms of imaging of patients. As we have just seen, I think the technology is mature enough to have a good enough imaging quality in the Angio Suite, and you should take advantage of this. And I'm going to explain you why and what is the WITRAS study. Because basically what we need to do when we are thinking about indication of a thrombectomy in acute stroke patient is to discard a large hemorrhage, a large established ischemic lesion, and to confirm a large vessel occlusion. So if we think that the technology is ready to do that, I think we should go ahead and start taking our patients directly to the Angio Suite. Because the imaging and that we're going to do also, it's not the way we're going to need to confirm these findings may be different if we are 1 hour away from symptom onset than if we are 7, 10, or 24 hours away from symptoms onset, obviously. A few years ago in the UK, we could find even this publication in which they were assessing the usefulness of doing best measures, and that included same-day CT scan. We're talking about same day within 20 or by next day, and at that point in 2013 in the UK, the rate of same-day CT scan for acute stroke was 47% or 69% by next day. So imagine how, and now we're talking about doing imaging within a few minutes from admission. So we are evolving, of course, we're progressing, and the same way we progressed with the analogy is clear with door-to-needle time with thrombolysis. Initially, when we started thrombolysis 22 years ago, 25 years ago, we were doing very few cases, and our numbers in the door-to-needle time were huge, about 2 hours to start treating a patient with IVTPA. Now, over the years, as we are increasing our volume, we could decrease dramatically the time down to 15, 20 minutes to confirm that the patient is candidate for IVTPA and start the infusion. So same way we're going to do with thrombectomy and time from door to groin time. We can do, first thing we need to do is we need to streamline and align all the stakeholders in our institution. And if we motivate everybody, we can go down, improve our numbers very well. As is shown in this study, after optimizing the workflow, they were able to reduce about 40 minutes the door to groin time. Still we're talking, even in an optimized setting, about 45 minutes in the CT scan to angio puncture. So still a lot of time that can be improved. What are we doing in my institution? In my institution, we promote pre-hospital alert. This is essential because all the team is waiting and activated for the patient. We avoid and we skip in ER always as possible, as much as possible. We take the patient directly to the CT scan. When we don't go directly to the Angio Suite, we ask EMS to take the patient directly to the CT scan, and this is where after non-contrast CT we can start immediately the bolus. So we can have door-to-needle times of 15, 18 minutes with this setting. And after the non-contrast CT, we can acquire contrast imaging and then take a decision about where the patient should go to the Angio Suite or to the stroke unit and so. It's a very well-known metric that is associated with outcome. That is the door to groin time. And you can see that a few years ago, 6 years ago already, there was a huge variability between sites. The best sites were performing about 75 minutes, which is today, it should be considered high, I think 75 minutes. At that time, it was the best site in this study. And you can see how it was directly related. The longer the door to groin time, the worse the outcome. So the poorer the outcome. So we should target this workflow time and reduce it as much and safely as possible. In trials, you can see what we were able to achieve in the latest published trials. This dawn was not so good, almost 2 hours. Swift Ram and Escape that were focusing on time, specifically achieved a few minutes below 1 hour in assessing the appropriateness of the inclusion criteria for thrombectomy and starting the procedure. About 1 hour, which is good, but still improvable, I think. So what would you allow to screen or your patient with a cone beam CT? So imagine a extreme case in which you had a perfectly fine patient that is coming to your Angio Suite for an angiogram, a diagnostic angiogram. He's asymptomatic, and at the moment that you shift him to the Angio Suite table, he becomes aphasic and hemiplegic. How many of you will take this patient out from the Angio Suite and go back to the CT scan to get conventional imaging? I guess few of you, most of you would probably do a cone beam CT to rule out a hemorrhage. And if there's no hemorrhage, within a very few minutes from onset of symptoms, you could start the groin puncture. So now the question is, how much this interval here, that in this case was a few minutes, would you allow to be long? Is it 1 hour, 2 hours, 3 hours, 6 hours or more, for which you could use a cone beam CT to select your patient for thrombectomy? And this is what we need to think about. Is it 3 hours? Is it 6 hours? The amount of time that you still think it's reasonable in which you can select your patient with a, with a cone beam CT. So we did this study in our setting with all the comprehensive stroke centers in Barcelona. More than almost 3,000 code stroke patients were admitted to these centers, and we wanted to see the differences between patients that finally underwent endovascular treatment or not, and basically the variables that could predict that this patient is going to have an endovascular treatment were his premorbid status as MRS, pre-stroke, his symptom severity, either scored by the Ray scale or the NIH on arrival, and the time and the aspects. So these were variables that could predict if that patient is going to be a thrombectomy patient or not. Most of the patients, in our setting at least, arrive within 3 hours from symptoms onset. So this is, each bar is 30 minutes from symptoms onset. Most of them arrive, like 90% of them arrive within the very first 3 hours. And you see that the rate of patients with an ischemic stroke is stable, about 60%. The rate of patients with a perfect aspects of 10 decreases, but you can still see how. So there is a decrease over the first 6 hours in the rate of patients with a perfect aspects. However, the rate of patients with an aspects good enough to indicate a thrombectomy is very high and remains above 90%, even up to 6 hours from onset. So very few patients would be admitted with a decrease in the aspect score that would, let's say, contraindicate a thrombectomy. Now, almost 40 to 50% of the patients will have a large vessel occlusion from those that were, and finally, about 30%, and this is a stable rate, will be finally thrombectomy candidates. So if we only can rule out that this patient has an ischemic stroke, not an hemorrhage, and this can be done with a cone beam CT, we can confirm an NIH greater than 10, and his pre-stroke ranking was 0 to 2. So only with this selection criteria, we can find that 60% of these candidates will be eligible for thrombectomy, only by doing this. So what are the options that we have when we admit patients in our institution? We could go to the emergency room. We should always try to avoid this, because this is, in my belief, a waste of time, because you need to go to the CT scan and you waste your time in this step here. So you should, as much as possible, go straight to the CT scan, or we can establish even some criteria, as we just seen, a high neurological deficit probably an NIH greater than 10, a pre-notification by EMS that allows that everybody is ready and in the Angio Suite, and within 6 hours, these are the criteria that we use to take the patient directly to the Angio Suite in our institution. So when we are, it doesn't mean we need to do it always, but if we are in the institution, if we are at the hospital, if we are ready to accept the patient in the Angio Suite that is empty at that point, if we were pre-notified and on admission we confirm an NIH greater than 10, we would take the patient straight to the Angio Suite. As you can see here, EMS will take the patient straight to the Angio Suite, and this is what happens. Within in a few minutes, everybody moves fast. We put the patient on the table, we prepare everything. Now we will acquire a cone-beam CT very fast. Here, we acquire a cone-beam CT 2-3 minutes after admission to the Angio Suite. We assess that there is no hemorrhage, and we are ready to start the groin puncture just 5 minutes after arrival to the Angio Suite. So very fast setting, everybody is prepared. And so imagine how much you can save time, how much time you can save by doing that. We have seen the technology is ready to rule out a hemorrhage. We've just seen this. The quality of the image is being better and better. With the present technology, we can optimize the visualization of the acquisition. And we even have a very good quality on the posterior fossa at least to find and to rule out an hemorrhage. So after ruling out that the patient does not have a hemorrhage, we can proceed either do a cone-beam CTA to confirm an occlusion with the cone-beam CTA, or we can confirm the occlusion with an angiogram, as we like to do in our institution. Both are fine. So we started in 2017 to take when possible, our patients directly to the Angio Suite. We could do that in around a third of cases because we were pre-notified and ready. So about 1/3 of the patients were taken directly to the Angio Suite. 1/3 would still go directly to the CT scan. And we need to minimize this as much as possible. Some patients, because we were not pre-notified, were still going to the emergency room initially. So we want to focus on the first group that went directly to the Angio Suite. And this is the price we're paying. When we pay patients directly to the Angio Suite, in some cases we find an hemorrhage. In some cases there is no occlusion that was not found either on cone-beam CTA or the initial angiogram. So about 25% of the patients here, and this will vary depending on your rate of primary admissions or mothership or drip and ship admissions, those patients that went through a primary stroke center in which a hemorrhage was ruled out. But you will have 25-30% of the patients that will finally not have a large vessel occlusion. So, and you would have taken them to the Angio Suite. This is the price you pay in order to get this. This is the benefit you get. You get a huge benefit in saving time. You go down in your door to groin time down to 15, even 8 minutes sometimes, but on average 20 minutes. If you compare to 56, 57, 60 minutes, so you're reducing 40 minutes. And as we were saying initially, tons, millions of neurons that you're saving with these 40 minutes. And the price you pay is you take a few more patients to the Angio Suite that would not need a thrombectomy. So what is the clinical impact? The clinical impact we've seen in our initial observations that many more patients had a dramatic clinical improvement. But and during the last years, many other institutions are adopting the same protocols. It's being more and more usual to see institutions that start doing this. Some of them like to do a cone-beam CTA before the groin puncture. Some others, like ours, don't. We have multiple publications right now with saving of times around between 20 minutes to 59 minutes, depending on the institutional workflows, but substantial save of time if you go directly to the Angio Suite. Now we need to prove the benefit, the clinical benefit of this. So from our initial study, we could not really see the clinical benefit because the groups were not balanced at baseline. Our direct transfer to Angio Suite had shorter onset to symptom times. But if we did a case control study in which we matched the patient by age, NIH, time from symptoms onset, and location of the occlusion, we could see in this initial case control study how, again, we reduced a lot our workflow time in the hospital, door to groin time puncture of 16 minutes, and that had an impact on the long-term follow outcome. More patients, like 13% increase in patients with no substantial disability. So, but what do we need to do to prove? We need to do randomized trials to finally prove that this measure is safe and effective. And this is what we aim to do with the WITRA study, in which we're going to randomize and we're going to have patients to conventional imaging or direct transfer to Angio Suite imaging diagnosis based on cone-beam CT, and finally those patients with a confirmed LVO, they will we'll look for differences in outcome at 3 months in those patients in which an LVO was confirmed. So here's another example in our institution. Are we, and the question that many people ask is, are we denying the benefits of IVTPA by doing so? And the answer is probably not. First, we're going to see probably in the next months that in this setting in which you can immediately start thrombectomy, probably IVTPA is not needed or does not offer much. But anyway, even so, we have already a wide experience of giving IVTPA based on cone-beam CT. We did that at that point, when we did this study, it was 20 patients, but right now we have more than 30 patients in which we gave IVTPA based on on cone-beam CT, and with very safe results. No increase in hemorrhagic transformation, especially symptomatic. None of those 30 patients had a symptomatic hemorrhagic transformation. And so very safe results. I think it's safe to give IVTPA based on cone-beam CT. And finally, what is the benefit of this direct transfer to Angio Suite according to time? And we did another study in which we had, again, case control study in which we compared direct transfer to Angio Suite patients with matched controls that went through conventional CT. And you can see that for all the groups, male, females, younger age, higher NIH, you see here favoring the direct transfer to Angio Suite. So overall, it looks like it favors all the groups. But if you focus on time, you see that with those patients that arrive very early, the benefit towards direct transfer to Angio Suite is even greater. And why is this? Why is this? So you can see, because here you can see for all the patients, direct transfer to Angio Suite versus direct transfer to CT. There is a benefit towards, in the ranking score 0, 1, 2, for those with direct transfer to Angio Suite. But now if we compare those within 0 to 3 hours and 3 to 6 hours, you see that the benefit is much higher within the early time window. And why is that? Because we managed to reduce about the same rate of time, about 45 to 50 minutes, independently from the onset, the time from onset. However, these 50 minutes are relatively have a higher impact in a shorter time. So these 50 minutes mean a 24 a higher impact on the overall time from onset if it's within 3 hours than if it's after 3 hours, and therefore your impact on the ranking score is greater at the earlier. So you can see the impact of taking the patient straight to the Angio Suite is especially high in the very first 3 hours, 2 hours, 3 hours, because reducing 30-40 minutes will have a higher impact within 1 hour than within 6 hours, and even less within later. So I would propose, and I think the benefits of the direct transfer to Angio Suite there is no need to do this beyond 6 hours, because probably at that point those fast progressors will have already a full infarct, and 1 hour will not make a difference, or 40 minutes, shortening 40 minutes will not make a difference. And for this slow progressors, Also, adding 40 minutes after 6 hours will not make much of a difference. However, imagine this 40 minutes difference for fast progressors after 1 or 2 hours from onset. Those are the patients who will really benefit from direct transfer to Angio Suite. Those fast progressors that are admitted within 1 or 2 hours from symptoms onset. So the WITRASH study that we designed here with Raul, again, with my co-PI, Raul Nogueira, because we both believe that this is really the way to go for this set of patients. We want to prove that on the prospective randomized study, and we designed this study with the help of Philips here. We want to involve 16 centers to recruit over 500 patients from 9 different countries in Europe, North America, and Latin America. We expect to include our first patient in January, hopefully, or February. We'll follow the patients for 3 months for the ranking score, and hopefully within 2 years we'll complete the trial. It's gonna be, as you can imagine, skipping the triage and the CT scan or the MR, and taking the patient straight to the Angio Suite. So this is the protocol. On arrival, after confirming that the patient is within 6 hours and has an NIH greater than 10, the patient will be randomized either to go straight to the Angio Suite and probably initiate a door-to-groin puncture of 15-20 minutes versus conventional imaging that will take a door-to-groin puncture longer, probably 45, 50, 60 minutes. So we're going to reduce 40 minutes the workflow, and this should have an impact here on the outcome finally. This is what we want to prove, and we believe that if we prove that on a prospective study, this management will be widely adopted in many other centers. This is what we want to achieve. Finally, I'm getting here to my last slide. We want to demonstrate that direct transfer triage is feasible, is superior, leading to a better outcome of patients than a conventional CT or MR triage workflow. And we hope we can impact the future of the treatment of the patients this way. So thanks for your attention, and I hope I was on time. Yes, right on time.